posteriorly from where you've marked it, and you reach around until you pull out a little vein. And what you're looking for when you do it is, if you look carefully, you can see kind of an upside down U, and one of those sides of the U is going in each direction. And so what we're going to do is grab that with a hemostat, and I've pulled from the one way already, and then basically we're going to use a hand-over-hand technique to pull the vein out from the skin. And the key thing here is that you never want to exert tension with your mosquito for more than about 1 centimeter from the skin. So in the video, you'll see I'll pull 1 centimeter of vein out, and then I'll re-grab it. I pull another centimeter out, and I re-grab it. For physics reasons that I can't explain to you, if you pull any more than 1 centimeter, 1.5 centimeters of the vein out, it just snaps, breaks, and then you have to find another vein somewhere else. So if you do this, you can actually get fairly long segments of vein. That's a vein right there, but in fact, the ones that you think might actually be the scariest to do are like in this lady, where we've done a saphenous vein ablation, and she has this cluster of grapes in her back thigh, and you can see with about 8 incisions there, pulled out probably about 3 or 4 feet of vein branches through that, and it was actually fairly easy and fairly quick. I suspect it took me a grand total of about 10 minutes to get those veins out like that. And then when you're done, you're left with little tiny incisions, which some people don't do anything with. They just put a compression stocking on because they'll get a little edema of the incision. The skin will coapt. We actually like to put some steri-strips across a wound, like you see, and then we'll put some tegaderm on top of that, and then we put a compression stocking. Some people like to wrap the leg. I've just found when we wrap the leg, you get very uneven compression, and when the patient takes the wrapping off, their leg looks like a corrugated box, and frequently you'll get blisters and the like from uneven pressure. So we put a stocking on the leg. You can actually see, if you look carefully at the leg from the tumescent anesthesia and the epinephrine, you'll see the pallor or the white skin over the area of the phlebectomies that are present. The other thing that we do now that we didn't used to do is we will now pad the entire area of the phlebectomies with gauze pads, and that just minimizes the amount of postoperative bruising that they get by putting a little extra pressure on the phlebectomy sites. So we put them in compression. Generally, phlebectomies are very painless, so people don't need anything more than Advil or Tylenol for pain afterwards. We let them resume normal activity the next day, with the exception of we don't like any of our patients to do any vigorous aerobic exercise for the first week. We don't like them to do anything that involves a Valsalva maneuver, and after a week they can return to normal activity. But believe it or not, you can do some fairly impressive veins in your office. So all my vein ablation procedures and phlebectomies are done in my office just under local anesthesia. We have the patients take a 0.5 milligram of Xanax about an hour before they come in, and if they're still anxious, we'll have them take a second 0.5 milligram. But we ablated this patient's saphenous vein in the upper half of the thigh. This was so chronic that what you're actually seeing, varicose, is actually the great saphenous vein that's so dilated and tortuous that appears like that. So we did that, and then we made phlebectomy incisions to remove the rest of the vein, and then you can see the patient's vein 6 to 8 weeks later. Again, here's another one that might be a little bit more typical of what you might see, but it's very successful, and this is literally with about 1 hour in the office. Now, I'm a surgeon, I do a lot of these, so I'm fairly facile at it, but I think that with time and practice and patience, people doing this can learn to do these and become pretty quick at it. Well, what about the complications? I guess that's what I was supposed to discuss. And as I said, if you do it right, you shouldn't see very many. But if we think about them, there's going to be complications with the skin, with the lymphatic system, and with the nerves. So the skin complications, the most common one really is none of the above, but would probably be hyperpigmentation. And I'm going to show you that in a second. You can occasionally get blistering from the steri-strips on the skin. Infection should be quite rare, one, because we do this using sterile technique, but two, as we learned earlier, that actually the tumescent anesthesia is bacteriostatic, and that may in fact explain why, for the 5,000 phlebectomy incisions that I make in a year, I probably see 1 or 2 patients that come back with a little bit of redness or something suggesting infection in one of the incisions. You can get induration, particularly in that first patient I saw that had those really big veins. They're left with a large potential space where the vein used to be. So if the padding isn't appropriate, that space will fill up with fluid, it'll get indurated, and it can take several months sometimes to resolve. So this is actually what hyperpigmentation looks like. It's kind of hard to see. You see this almost universally after sclerotherapy, but in this case, if you look in the distal thigh where that vein used to be, you can see just some faint brown skin discoloration where the line or where the vein used to be, and that tends to fade away in 3 to 6 months. Skin dimpling looks like this. You're actually going to see this photo later on again, but if you look, this patient had matching veins in her thigh, and I've treated the vein in her right leg. One thing when you're doing a phlebectomy is you want to avoid removing any fat from the patient's leg. And so sometimes as you're pulling the vein out, you'll see a big chunk of fat. You'll literally want to strip that off, push it back in the skin, because if you take a big chunk of fat out, particularly in a patient that's thin, the dermis, the posterior surface of the dermis will become attached to the superficial fascia below, and they'll get a little skin dimple like that. Lymphatic complications are rare, but sometimes there will be little lymphatic channels that are running right alongside the vein, and when you avulse the vein, you will avulse that lymph channel. And you'll know it because the most common thing that happens is patients will come back 2 weeks later and they'll say, "Doc, I've got my varicose veins back." And you look at their leg and they have a walnut-sized lump in it. And if you aspirate it, you'll just get clear lymphatic fluid out of it. And when I first started seeing this, I really didn't know exactly what to do. But now it's a fairly simple treatment. What I do when I see this is I actually take a 3 cc syringe and I aspirate the lymphocele empty, and then I actually inject a cc of 3% sotodecol, and I literally swish it in and out around the inside of the vein. That creates inflammation within this lymphocele. I put a compression stocking on their leg, and it goes away and stays away. So it's actually fairly simple to treat. I've never actually seen lymph draining out of a wound. And occasionally, despite all the best that we do, you will see an occasional patient who, after a vein ablation or after a vein ablation with a phlebectomy, will have edema of the leg, probably just as a result of the inflammatory reaction that occurs that will last several months and up to a year. Since I do them at the same time, I never know whether it's due to the vein ablation or due to the phlebectomies that I did. But we'll see that maybe in about 1 out of every 100 or 150 patients will come in with some mild edema that's worse than it was before. Nerve complications should be very infrequent. You heard earlier today about the risk of grabbing the saphenous nerve or the sural nerve. Generally, if you're dealing just with varicosities, the only thing you'll notice is occasionally you will pull a small sensory branch of the nerve up with the vein as you grab it with your hook. And you'll know you did it because the patient will say, "Yow, it hurts," because they'll get a shooting pain that goes all the way down to their foot and all the way back up into their thigh. And the best thing to do when that happens is to just stick the vein back down underneath your incision and move somewhere else, because it seems every time I keep trying to grab a vein there, I still grab the nerve. Even if you wind up grabbing the nerve and pulling it and avulsing it, the patient's going to have some pain for a few minutes. I'll generally put some tumescent anesthesia below and above to anesthetize the nerve, and rarely have I seen patients that have come back with numb spots or dysesthesia in their leg. A traumatic neuroma is something that's discussed. I've actually never seen it. In conclusion, though, phlebectomy is a technique that I think you all can learn and master with time. I think it gives a far better cosmetic result in a shorter period of time than sclerotherapy, and complications should be few and can be minimized by using the proper technique. Now, can you play the video? So I have a video that runs for about 9 minutes, and we might stop it early depending on...
It's okay.
Anyone have any questions while they're queuing that up? Romy? I'm sorry?
Instead of phlebectomy,
Yes.
once I've ablated the upper segment, I just foam the whole thing and let it just sit there. And it's amazing how that thing just shrinks down. Then with the wrap, not an incision, got a few patients with the same result.
Right, and I think that when you see some of these newer foam sclerotherapy products that are coming out, that may in fact be a fairly good solution for some of these patients.
I've just been using sotodecol.
Right. Correct. Well, as we talked earlier, the other thing you can do is tumescent that and give that a try sometimes. But let's run the video here, and then we'll... So this just shows I have a 22 gauge needle that's hooked up to an infusion pump. And once that starts playing, you'll see that this is actually the inner thigh of a patient. And I've done my preoperative marking of the patient. And generally the little circles that you see are areas where the vein is kind of knuckled up and is right underneath the skin. And I know if I make a skin incision just posterior that, I will find the vein. Do you think the videos, will it play? Okay, go ahead. That's great. Okay. And so you can, if you look and see frequently, once you stick the needle in once, all your subsequent sticks should be in an area where it's anesthetized. And if you look carefully here, you'll see that the tumescent anesthesia will frequently dissect your vein out for you. There'll be a couple shots of this where you'll actually see the tumescent. Like right here, if you watch here, I think you'll see that it's actually going to travel right down the vein. And so it actually does part of the work for you. Just watch right there and you can see that in fact it's traveling down the whole vein. So it actually makes it very, very easy to get the vein out. And here are the mosquitoes we use. We have a little sterilizer in the office so we can sterilize it. And this is a basic vein hook that we use. This is actually one made in America by a guy named Sam Wagner. But we make a little incision that you're going to see, hopefully is going to be vertical, but I guess you're not going to see that. And again, I hold the hook in the palm of my hand, and then I just kind of reach around in the incision trying to find the vein. I think I actually struggle to find it in this one spot. And the beauty of making such small incisions is if you don't get a vein out where you've placed your hook, you just move on somewhere else and no one's ever going to be able to see this incision. In the old days, we used to make these 1-inch incisions, and it was quite embarrassing when patients would come back to the office with a big incision and a big varicose vein sitting right underneath it. So you'll see I'm kind of working here and not really finding too much. And I'm generally going to just move around. But you can see there, I have the vein. And when you finally hook the vein, it feels like you've grabbed a thick rubber band under the skin. It has a little bit of resilience to it. It has that pearly white color. And you're going to see I'm going to grab it with a mosquito. And then I'm going to just slowly pull. And if you notice, one, I'm palming the instrument, and two, I'm exerting all the pressure on the vein with my index finger down by the nose of the mosquito. So you have a fair amount of control. And there I have the little V part of the vein that we see. You can see it's headed up that way. And so I'm going to just keep pulling slowly, grabbing a little centimeter at a time. It seems kind of arduous, but you'll actually get some fairly dramatic pieces of vein. And eventually, I'm going to kind of get a sense of how much vein I pulled out here. You can see right there is where I think I'm grabbing it from. And then when the vein does finally tear, which it's going to do at some point, you'll notice, one, how little blood actually comes out because you've eliminated the saphenous reflux there. I'm going to lay the vein down, and I figure that I've got it to there. So when I make my next skin incision, I'm going to make it kind of an equivalent distance down. Now this part of the vein is headed back to the saphenous vein where it originated, and it's actually going to tear pretty quickly here. And that's it. See, there's a little bit of bleeding there. I'll hold pressure just for a second and it disappears. Then we're going to move down an equivalent distance, make another little incision. And again, the only thing that should ever penetrate the incision is your hook. So if you can't find the vein, don't make the skin incision bigger and stick your hemostat in there, but just go somewhere else. And again, if I don't find it where I think it should be, then I keep searching all the quadrants. But you can see I sort of feel like I have something there finally. And again, I'm going to pull it up, grab it, and then it becomes just kind of the same thing, over and over and over again. I will tell you, though, that by the time you eliminate saphenous reflux and make 6 or 8 incisions and remove most of the proximal varicosities, almost everything else in the leg will disappear and you'll need to do nothing further. So again, you'll see I just grab a centimeter at a time, just have to kind of be patient. And remember, this is all being done in the office just with tumescent anesthesia. So now I'm going to turn around. The other thing that you want to try to do is you always want to try to exert the force going along the length of the vein. You don't want to be pulling at right angles because it will tear pretty quickly. So again, it becomes fairly repetitive after a while, but every time the vein comes up, it's the same every time. Right there, I just I just tore it right there. And what I'm going to do is I'm going to just reach up and drag my hook under the skin a little bit. And you'll see when I do this here, when your hook just passes easily between all your incisions like that, you know that you've left no residual saphenous vein segments behind. And even if you do leave one or two behind, because you've eliminated the reflux, you're going to wind up having those veins just fibrose and atrophy and shrink. So does phlebectomy work great for everybody? No. It works best for patients who have not had any previous vein treatments before. Generally, if veins have been phlebitic or patients have had extensive sclerotherapy in the past, there's going to be a lot of perivenous inflammation, and the vein's going to be fairly stuck, and you're going to have a difficult time removing a lot of the varicosities. So in those patients, I will treat them with sclerotherapy instead of phlebectomy. So you can see this is kind of headed down towards the knee right there. Again, I'm just pointing out that I palm the instruments in my hand. I don't put my fingers through the holes of the mosquito. It gives me a little bit more control. It takes a little practice to be able to do it. But I pulled that part out, and now I'm going to try to pull along the axis of the vein. You can sometimes stretch and feel which way the vein's going. Along the knee here, you're going to see I'm going to make my incision I'm just sort of pointing out those lines, and I'm going to make my incisions right in the line that I see, right in the skin. The other thing that you want to avoid doing is making an incision in any of your ink marks, because if you do that, you will occasionally drag the ink inside the skin and tattoo the patient's leg. So you want to avoid that. You just want to avoid it. There's no reason why you shouldn't be able to avoid it. And again, you see I'm going to pull enough up that I'm going to be able to see the two segments of the vein. I'm going to grab the one that's going inferiorly. And again, they just kind of inch out along the way. And you'd really be amazed once you've done a few of these things how well you can do. What I tell people who are just getting started with phlebectomies is get the instruments and don't charge a patient. Just do your vein ablation, then put some tumescent at the end and make it a couple incisions. And just try to get a little experience. And you'll find once you grab one vein, before you know it, you'll be grabbing the next. And within 3 or 4 sessions, you're going to be pretty facile with it. So I think there's just one more vein here, and then we'll show you the dressings. And at this point here, usually what I do is try to make multiple incisions at the same time so I don't have to pick the knife up repeatedly. And we're going to just go in and just say, after a while, it's all the same. The one area that I'm always particularly careful about is when I'm making phlebectomy incisions by the fibular head, because that's the one area where right underneath the fibular head is the fascia, and right underneath the fascia is the perineal nerve. I've never done it, but I can envision how someone could not find a vein and be aggressive enough and poke their hook through the fascia, grab the perineal nerve, and avulse the perineal nerve. So I'm always cautious there. The other area I'm quite cautious about is on top of the foot. Now, I do a lot of phlebectomies on top of feet, but you should know that there are lots of nerves, probably twice as many little sensory nerves on top of the foot as there are elsewhere. And so it's very easy to grab those nerve branches. And again, you know it right away, because as soon as you hook a nerve branch, it feels like you've pulled up a little nylon banjo string into the wound, and it just has a different sensation than a vein does. Are there any questions while we're watching here? Was that a question, or is that, no? So there you go. I think this is the last one, and then you'll see what we do for dressings afterwards. Again, I'm always looking for that little U. It's not quite as exciting as recanalizing a superficial femoral artery, but generally your patients are far more grateful because they come back and they're really pleased that their leg looks great. And so at the end, we simply put some steri-strips on the leg. We use some special steri-strips that actually have a little bit of elasticity. We don't use benzoin. If you use white steri-strips and benzoin and the leg swells at all, you're going to wind up getting blisters. And then we'll usually put a piece of tegaderm if we've done a bunch of them to keep them covered. And then over that, we'll put their stocking with some gauze. So questions? Are you all ready to grab your syringe of tumescent, your scalpel, and your hemostats? Okay, thank you.
Thank you, Dr. Allen. Now, I'm the one to present the next subject about how we do sclerotherapy in Brazil. I was invited by Dr. Patricia and Dr. Jafar. Thank you very much for the invitation. And I'll start this presentation telling you why we do this kind of sclerotherapy treatments in Brazil, because it's important. So this is where we live. We live in Brazil, which is a hot, hot sun place to live. So we have almost 8 months of hot weather, and the other 4 months are very hot too. So, so we just have to care about our patients because they really want to show themselves to each other. And on top of that, we have about 5,000 miles of Atlantic coast. So they really want to show themselves to their husbands and their friends. So this is why they are so demanding when they come to our offices and ask to be treated and get rid of their veins. So this is the kind of patients that we have in Brazil. This is one of my patients, and they are very, very demanding. So, sure. Well, but you know, actually, I'm showing this picture because they are actually a problem because they are very demanding about how their legs look like. So this kind of presentation is not acceptable at all. What they want is this kind of presentation, and they will do whatever they need to have us doing and making their legs look like that. So what we are talking here is not phlebectomy, not larger veins, so I'm just keeping us into this subject, which is telangiectasias, which is by definition dilated superficial vessels visible to a naked eye. So this is what they don't want. So they don't want anybody to see their veins, and they want us to treat it. There are small veins, so when we move from telangiectasias to larger veins, we are talking about phlebectomies. And there are many causes to that, and we already discussed this earlier. And one of them is, of course, pregnancy. And after that, we have so many patients coming to our offices to fix their legs. That is amazing. So what they want is us to do magic, is us to do a miracle. But we are not gods. Neurologists are gods. We're not. We're just vascular surgeons. So what we keep telling them is that treating those veins is a process, is a long-term process that they will have to come to our offices very often until we get to the point that to their satisfaction. So what we do, we now use every possible technology to treat those small veins. So we're talking about foam sclerotherapy, we're talking about laser sclerotherapy, and we are talking about chemical sclerotherapy. So we almost use all of them at the same time to get to the point that the veins are gone. Chemical sclerotherapy, we use in Brazil something that I didn't find here, which is hypertonic glucose. They don't use that in the United States, but this is the most used liquid sclerosant in Brazil. And we do have good results using glucose. It's like 50% glucose, 75% glucose. And when we do that, we combine with foam sclerotherapy and laser sclerotherapy. So how do we do that? Sometimes you do have a pre-sclerotherapy treatment which involves surgery, just like we saw here. So when the saphenous vein is included, we First of all, we do treat the saphenous vein because we go from larger veins to smaller veins in our protocol to treat varicose. So what we do first is to treat the saphenous vein trunk and everything that is larger than 1 centimeter, and then we go down, and sometimes we combine at the same time we're doing the saphenectomy to phlebectomy and even fun sclerotherapy for those smaller veins. After that, the patient will come back to our office, and then we can do in an ambulatory set even phlebectomy if one vein was left, and fun sclerotherapy also, but then we move for the laser and the chemical sclerotherapy treatment. Well, when I say that, it seems that it's easier, but in order to do that, we have 2 physicians and 1 nurse working all together at the same time. What we do, we find all the veins, we map all the veins with vein light or vein view. Then the nurse will go and take the patient to one room and do topic anesthesia for 1 hour. So when start doing the procedure, she had this kind of topic anesthesia before doing the procedures. Then we first do treat the feeding veins with foam or even phlebectomy at the same time in our office. After that, you do treat the smaller veins, and we prefer to treat with glucose because we are used to do that, and this is where we get the best results. So we have 2 physicians doing this at the same time with the same patient. Sometimes what we do have is one of them is doing laser therapy on the upper side of, upper body, face, and neck, and one of them is doing sclerotherapy in her legs. For the feet, we usually don't do any chemical or foam sclerotherapy because our patients really don't like it. So the laser goes down from the face to the feet, and we do laser therapy for those smaller veins. After that, what we do is to use those bandages, elastic bandages. They just look like that, and the patient will use that until that first night, and then she takes it off and don't use it anymore. And this is how we get the best results for sclerotherapy. So doing that is how we get the best results, and our patients are really happy, and so are we, and we don't have much of a problem treating those girls. Thank you.
Romy?
Oh.
How do you pay for it?
Oh, I forgot to tell you that those patients, they come to our office every 15 to 3 weeks, but these are the ones that are doing Botox every 6 months and the ones that are doing plastic surgery every year. So they really don't care about paying this, and the insurance companies don't cover this type of treatment in Brazil, so they just have to pay. But these are not the ones that are really caring about the price.
Yeah.
Somebody's starting a venous program, someone's starting sclerotherapy. What's a good cost range to look at
The cost?
in the U.S.?
Well, we're going to see both because I'm kind of curious. So, in the U.S., I'm going to actually go through the different strengths and solutions when I go through my talk in a minute. But as far as a cost goes, we charge a fixed amount. I really can't say publicly because then we'd all be accused of collusion. But I will tell you that there are some people who charge a fixed cost ranging anywhere from $300 per session to $500 per session, a session being anywhere from 15 minutes to 45 minutes. Some people charge per syringe of sclerosant they use. They might charge $250 for every 3 cc's of sclerosant they use. I know someone who charges per injection. He has a nurse making little check marks, and every injection is $18. And at the end, somehow he always manages to do about $600 worth of needle sticks per session. But that's sort of how it works out. So that's the way we do it. But I'm really curious to find out. Mm-hmm. So if I come in and I got to get my face done and my legs done, and how do you do that?
Actually, we do charge for each session of sclerotherapy. It is you were saying that, I was making the math here, is about $500 each session. It doesn't mean that you're going to do everything in that single session. So even the face and the legs won't be done in just one session. So she will have to come back and do that usually they come once a month or twice a month. It depends that if they have a trip, or if they're planning to go to the beach or something like that. And so they would ask for to stay there a whole morning doing everything. So, but we charge for each session. And glucose is pretty cheap. So we won't charge too much for that.
Has anyone here ever used glucose? I mean, I really up until now was not even familiar with it as a sclerosing agent.
It's like saline, hypertonic saline, but I mean, we learned that like 50 years ago with the French guys, and I think that France and Brazil are the ones that are using glucose most for sclerotherapy, but the results are pretty good.
And when you use laser, do you only use it in the face, or do you also use it in the legs, and how small vessels do you laser?
It depends, because if you want a pretty fast result, our preference is to use glucose, because when you inject and you have all those veins going away, the results are faster than using the laser for going point by point. So we do keep the laser for the smallest veins and where they are very painful to treat. So we just divide everything. And it's kind of a cultural thing in Brazil that everyone does the glucose, the chemical sclerotherapy. So, who else?
Is there less matter with
It is. Well, this is another thing that we learned to start every patient with the lowest concentration of glucose, or the lowest energy with laser, and we are just going up after the first session, and we see the results, and then we decide to have another concentration and go up until we get the results. We started using the dermatology skin type classification. So we go from the lowest concentration to the highest. Well, they are not allowed to go out from the office and go to the sun. But in the south part of Brazil, there is a group of vascular surgeons that they sell this idea that it is important to go to the sun after sclerotherapy. And they just, every Brazilian vascular meeting, they just come over and over again defending this idea, this concept that it is important to go to the sun after sclerotherapy. But we just don't. We just ask them to keep away from the sun until the small bruises or even those skin marks go away. That's it? Okay, so he's back.
Okay, so for our final topic of the afternoon, we're going to talk about sclerotherapy in America. And I can assure you it is not nearly as beautiful a thing. So if you can put my slides up here. So there's the topic. So you guys know what sclerotherapy is. Basically, it's ablating a vein by a chemical, and what you're trying to do is create an inflammatory reaction within the vein that you treat, which will result in eventual fibrosis and obliteration of the lumen of the vessel. So in America, these are the sclerosants that we use. The only ones on that list that are actually FDA approved are sodium moreuate, sotodecol, and polydocanol. All the others are off-label. And I think that glycerin is probably the closest to the hypertonic glucose that Francesco was talking about, but we'll talk about that in a second. So sotodecol is an approved sclerosant in America. It's probably the most effective of all the sclerosants. It can be used anywhere from a concentration of 0.1% for small spider veins all the way up to 3% if you're trying to ablate a great saphenous vein. It can also be foamed. The main drawback to sotodecol is it's associated with the most hyperpigmentation of any of the solutions that we have, and it can also cause tissue necrosis when it's extravasated. Generally, if you're using sotodecol with a concentration of 0.2% or less, even if you get an intradermal injection, you will not get necrosis. There are rare reports of allergic reactions. The other approved agent now that's commonly used, it was approved I think in 2010, is polydocanol, which goes by the brand name Asclera, and it's a long-chain fatty acid that acts as a detergent. The nice part about Asclera is that it's painless when it's injected, but the second it extravasates, patients get instant severe pain, so you know that you're extravasating and you can stop your injection. There's a low incidence of allergic reaction in skin necrosis, although it does occur, and they seem to get less hyperpigmentation than you do with sotodecol. Both of those agents, because they're detergents, like a detergent, you can foam them, and the method that we use here in America is called the Tessari technique, where you take 2 3cc syringes and generally use 1 part of solution to anywhere from 3 to 6 parts of air, and you, through a 3-way stopcock, create suds. The advantage of it, it makes the solution more potent, and it increases the contact time of the solution within the vein. So as Romy was saying, when you inject it, it just sits in the vein for minutes and minutes and minutes. I have to tell you, though, that foam, sotodecol, and foam Asclera are not approved drugs. The aqueous solution is. The foam solution is considered a different drug, and it is not approved. So in particular, you really can't bill Medicare for a procedure that you use with a non-approved drug. That is a crime. So keep that in mind. I'm not saying I don't do it, but I don't do it for Medicare patients unless they're paying cash. And the reason that foam hasn't been approved yet is that because of patients having right to left shunts, there are occasionally patients who will have strokes or visual disturbances from air getting into their central nervous system. Things that have been done to minimize it are that when we do use foam, we never use more than 6 cc's in a session. And secondly, some people have reported if you actually have the patient elevate their leg for 10 minutes following the procedure to keep the foam in the extremity, that it minimizes the amount of bubbles you see in the heart afterwards if you check. Glycerin is an agent that is not FDA approved. It's an off-label use. It's a chemical irritant, and I think it's really kind of an ideal agent for patients with small pink little veins in their leg. The nice part about it is they tend not to get much hyperpigmentation. The veins tend not to look worse before they look better, and they tend to get a nice cosmetic result, but it only really works with the very small, fine little veins. The reason that I don't use glycerin, well, I'll get to that in a second. Hypertonic saline is also an off-label use. Hypertonic saline is approved to induce third trimester abortions. It is not approved as a sclerosing agent, so it's an off-label use. It causes craniation of the endothelial lining cells through an osmotic process. The nice part is it's readily available, it's inexpensive, and it doesn't cause allergic reactions. The downside is it really hurts a lot when you inject it, even if you dilute it with lidocaine, and it can cause ulceration with extravasation. I kind of call hypertonic saline the amateur solution because it's used commonly by people who just want to do a little sclerotherapy but haven't spent much time studying it. I found it to be very painful and not particularly effective. So the only time we use it is when patients are allergic to sotodecol. Now the concentrations of the 2 agents, and again in my practice we exclusively use the 2 FDA-approved drugs, sotodecol and Asclera. And for spider veins, generally use a concentration of sotodecol of 0.1 to 0.15%. Reticular veins, 0.2 to 0.3%, and branch varicosities anywhere from 0.5% all the way up to 1 or 2%. And the same with the sclera, you can use it as 0.25 to 0.5, and as you see there. So, and I agree with Francesco in that what you really want to do, and what we do, is we start off at the lowest concentration solution. And the worst thing that happens is it doesn't work. And then you move up from there. If you start off at the highest concentration, you're more likely to get ulceration, you're more likely to get matting, and hyperpigmentation. We're going to talk about that later. This is a study, and I would just, there's a lot of reasons why, I'm not pimping for pharmaceutical companies here, but this is a study that Mitch Goldman, a dermatologist, did where he actually ordered 3% sotodecol from a variety of compounding pharmacies, and he found that, in fact, when you really measured the concentration of sotodecol in those solutions, it varied from 2.6 to 3.4%. So what you think is 3% really isn't. The way we use sotodecol is we take 3 cc's of 3% sotodecol, which costs roughly $70, and we dilute it in 27 cc's of saline, and it gives us a 30 cc bottle of 0.3% sotodecol, and that's our stock solution, and we dilute everything from there for a patient basis. So basically, we can treat probably 6 to 8 patients with sotodecol for a total of $70. So it's very inexpensive. If you got it from a compounding pharmacy, it might cost you, a quarter of that amount. But with the recent events surrounding epidural steroid cortisone that was done from compounding pharmacies, I'm really not interested in getting involved in a contaminated drug from a compounding pharmacy, particularly when there's an FDA-approved product on the market. And this just kind of goes through the cost of the two. A sclera is a lot more expensive than sotodecol, and so we primarily use sotodecol. We tend to use the sclera primarily just for the really small pink little spider veins in the patient where they're going to get less hyperpigmentation. The indications, as I've indicated here, we use them for varicose veins 4 millimeters or less. I use about half the perforated veins I treat with sclerotherapy. If someone has isolated segments of recanalase saphenous vein after a vein ablation, we'll use sclerotherapy, and then we use it to treat reticular veins and spider veins. And this is just an example of a varicose vein that we would treat with sclerotherapy. You're actually going to get to see the after picture later. These are reticular veins, or dilated subcutaneous or non-dilated subcutaneous veins that generally feed the spider veins. This is a common vein. You see, this is a lateral thigh of a patient. This is called the lateral vein of Albanese, and you can't see it here. You can see it well with the vein light, but there's a vein that actually refluxes from distal to proximal and feeds this sunburst pattern of spider veins in the outer thigh, and you have to treat the reticular vein in addition to treating the spider veins. And lastly, these are what are called venectasias, which are veins where there's almost no skin left. The veins are protruding through the skin, and here's kind of a before and after. You can get nice cosmetics results with these people. And then these are your typical spider veins that you see treated. This is the equipment that we have in the office. And the most important part of the equipment that you see there is the vein light, and that's sitting to the right. And that allows you to transilluminate the skin and see the underlying reticular veins that you can't see with your naked eye. One question that I get asked frequently is, do you do Doppler ultrasounds or venous imaging studies on all your patients that you're treating for spider veins? And the answer is we do not. But there are a few patients where we do. Patients who just have massive spider veins on both legs, we'll check to make sure they don't have underlying saphenous reflux. Patients who have lots of spider veins on one leg and no spider veins on the other leg will duplex. And lastly, people that have certain distribution of spider veins, like in this particular patient, even though she had no varicose veins, she had all these spider veins right by the medial malleolus. And in fact, this generally is associated with massive saphenous reflux, and we will duplex them first and treat as appropriate. We do a standard history and physical on a patient, but then we spend a fair amount of time educating a patient. We always take pre-treatment photographs for two reasons. One, if you're new to this, as some of you may be, you never remember what your patient's veins look like beforehand, so you don't know whether the therapy you're giving is effective or not. So if you have pictures to show you what it looked like before you started, what it looks like 4 weeks later and 8 weeks later, you can adjust your behavior, change the concentration of your solutions and the like, and you can get fairly facile fairly quickly doing sclerotherapy. But more importantly, patients never remember what their veins look like, and I'm going to show you an example of that in a second. We have them sign a consent form talking about all the risks and benefits. And lastly, we try to manage expectations. And as we heard about in Brazil, the expectations in America are not a whole lot less than they are in Brazil, and patients expect their legs to look perfect. And so it's very stressful. I have a nurse practitioner who does all the sclerotherapy in our office, and dealing with unhappy patients is a big part of her job, and so it's trying to manage expectations. So here's an example of what I mean with these patients. If you saw this picture of skin dimpling earlier, but if you look at those veins on the left side of her leg, they're pretty bad. Well, she came back to my office 3 years later for something else, and I said, well, how are your legs doing? And she says, oh, doctor, they're terrible. I don't know why I did anything. They're no better than they used to be before. I don't know why I started. And I'd happen to remember this patient, and I said, well, let's take a picture. And this is actually what her veins look like now. All her varicosities are gone, and all she has is a few spider veins. I'm not going to remember what they look like. She's not going to remember what they look like. So if you don't take photographs, you're not going to have happy patients because they're really not going to have any idea about the degree of improvement they've really obtained from your therapies. The principles of treatment, we talked about this a little bit, but basically we use a 30-gauge needle, and you see we bend it just about 20 degrees at the hub. We always survey the area that we're treating with a vein light before we treat it to make sure there's no underlying reticular veins that need to be treated. So we talked about, we go from large to small to smallest, varicose to reticular telangiectasias. We try to limit each injection to maybe 1/10 of a cc all the way up to 1/2 a cc per injection. And basically you want to inject slowly without pressure. The tendency when you see a big spider vein is to just inject and force the stuff in and see how far out you can get the solution to disseminate before you quit. But remember, the further the solution gets from the vein, the more dilute it is with blood. And so if you're starting off with 0.15% sotodecol, by the time it gets 3 centimeters from the vein, it's probably 0.07% sotodecol and the like. Furthermore, when you inject with a lot of pressure, you can open up a lot of microscopic capillaries that can lead to something called matting, which we're going to see in a little bit. So we try to literally almost trickle the solution into the vein. We're very careful about treating veins over the tibia, and in particularly around the medium malleolus, because around the medium malleolus there are lots of little arterial branches down there that look like veins. And one of the ways you can get venous ulcers after this is to inject an arteriole inadvertently. You really have no idea because they look the same, so we're very cautious there. We put patients in compression afterwards. We try to use stockings, or sometimes we'll wrap the leg. We have them wear it for 3 to 5 days afterwards, but I don't know if it makes much difference than wearing it just 24 hours. And this is the advantage of a vein light. You can see on the left, you can see a spider vein, and before the vein light, I would have just injected the spider vein and gotten a mediocre result. But when you put that vein light on there, you can see that faint little blue vein leading into and leading away from the spider vein. So that's a reticular vein that's feeding this vein, and if you don't treat it first, because that's the proximal most point of reflux for the spider vein itself is not going to go away, or if it goes away, it's just going to go away partially. So you have to identify those reticular veins. Then we talked about compression. We let people exercise right away. We try to have them avoid aerobic activities for the first week or so afterwards. Complications. Well, some of these are complications and some of these are side effects. Almost everyone after sclerotherapy gets some degree of hyperpigmentation. It's a result when you denude the endothelium. The endothelium is an anticoagulant. Despite the compression, blood creeps back into the vein. And it thromboses. When it breaks down, it breaks into iron pigment, hemosiderin, which leaches into the skin and gives hyperpigmentation. It generally resolves in 6 to 12 months, but by doing what we call a microflebectomy 4 to 6 weeks after the procedure, you will minimize the amount of hyperpigmentation. So this is a lady that I injected the spider veins on her thigh, and she didn't come back 6 weeks later, but she came back a year later, wanted to know why she had these big brown marks on her leg. And I said, you had those big brown marks because you didn't come back 6 weeks later to have the blood evacuated from your leg. And so this is what the microthrombectomy is. Basically, 3 to 6 weeks after sclerotherapy, we take a little beaver blade or 22-gauge needle, make small little incisions, and then we evacuate the vein rolling 2 Q-tips. And so here's a little spider vein on the right medial calf of a patient that was injected. And again, patients always think they're just going to disappear, but in fact, this is what they look like 3 to 4 weeks later. They look even worse sometimes than they did before. So a specific part of our consent says no matter what kind of result you think you've got from your sclerotherapy, you have to come back 4 weeks after your procedure. Because some patients will call back at this point and say, I'm canceling my appointment, I spent $300 and I'm no better than I was before. But when you have that thrombus trapped in there, what you do is you take a little 22 gauge needle, and by 3 weeks the thrombus has liquefied, and you poke it in 3 or 4 spots and you gently roll to the center with 2 Q-tips, and you'll wind up getting anywhere from 50 to 90% of the thrombus out, and then the rest of the spider vein disappears very quickly with minimal hyperpigmentation. But if you don't do this, you're going to get a fair amount of hyperpigmentation. And this just shows how it resolves. The picture on top is before treatment. The picture in the middle is 3 months later after she's had her sclerotherapy, had her evacuation. She has some mild hyperpigmentation. And the bottom picture is at a year, and most of it has faded away. And this is part of managing expectations. Patients are always expecting that you're going to inject and their vein is going to go away. But in fact, it's a process, and it takes really, we tell them it takes 3 to 6 weeks before you notice improvement and 3 to 6 months before you get an optimal appearance, and even longer. So we see a lot of patients who have a little sclerotherapy, they're disappointed, they don't come back, and then 6 months later they come back and they go, God, this looks great, I want to get the rest of them done. We talked about the ankles, and we learned how in Brazil they don't like to do them by the ankles, and this is one of the reasons why. This is a patient we saw that had sclerotherapy done somewhere else, and this is after the first session in the top photo. They just did it and said, you know, you don't need to come back and see us, but you can see all the intravenous thrombus that the patient had there. So we, in fact, evacuated the thrombus, did some additional sclerotherapy, and that's his ankle by 6 months. There's still some hyperpigmentation, but he was quite pleased. It looked much better, and by a year, most of that hyperpigmentation had faded away. Matting is the appearance of these tiny little red veins following injection. We think it generally occurs either when you use forceful injection or you use too high a concentration solution. And that's one of the reasons we like to start low and go high. It's generally an inflammatory reaction in the skin. The best thing to do is to just do nothing, because generally it will go away by itself if you do nothing. If it doesn't, we'll assess the patient to make sure we didn't miss proximal reflux. But this is what matting looked like. This patient came in with a few little spider veins like you saw in that patient earlier, but in place now she has this pink little mat of veins there, and it's very difficult to treat. Patients are very disappointed afterwards, and the best way to avoid it is start low concentration and inject with little pressure. Well, this is a jack of all trades. You don't want to get one of these, but this is actually a skin ulcer, and this I actually got after using a sclera, and I actually did it. And what happens, generally, if you inject enough of the solution outside the vein, it will cause tissue necrosis. There's some people that think the only time you get skin ulceration is when you inject an arterial inadvertently, but I think that both mechanisms probably are valid. And these are full-thickness ulcers. They take 3 to 4 months to heal. They're painful. They usually become infected at some point along the way. And the worst part in the end is the patient's left with a scar that they're not happy about. And here's just another example of a couple little superficial ulcerations from sclerotherapy. You can tell so far we have not had a great success with that patient. When you're doing larger varicose veins, one of the common things you can get is you can get phlebitis, because remember, you're basically with sclerotherapy, you're creating a chemical phlebitis within the vein. Sometimes it's more overt than that, and they get redness, tenderness over the varicosity, and it's treated like any phlebitis with non-steroidals, heat, compression, and eventually it gets better. If it's very close to the skin, we'll evacuate thrombus 3 to 6 weeks later. Allergic reactions are very rare. I've never seen one, but we do keep an EpiPen in the office just in case. And here are just a few examples. On the left is that patient we saw earlier with varicose veins. On the right, there's her after picture. And to show you how difficult this can be, I showed this picture to my office manager because I thought it was so great I wanted to put it on my website. And my office manager said, "Are you kidding? That picture on the right, that's not any better." And I said, "Are you kidding me?" But in fact, there's hyperpigmentation there, which is which is what happens afterwards. But that will fade away. I personally think it's a very dramatic result, and the patient was quite pleased. This just shows the evolution. On the left is a patient before we treated her. In the middle is 6 weeks afterwards. You can see the veins are partially gone. There's some intravenous hematoma. There's a little bit of hyperpigmentation. And 3 months later, you can see the back of her leg looks great, and she was quite pleased. And just another example of results. So in conclusion, I think sclerotherapy can be learned. It doesn't have to be done by physicians. It's a great thing for a mid-level provider to do, and they can be a great asset to your practice. My recommendation is that you start off using one agent, and I think Sotodecol is probably the least expensive and the most versatile one, and get really good with that agent. Learn the strengths, learn the weaknesses, and really understand it, and then once you figure out where it doesn't work the best, then add a second agent, in this case the sclera, to your treatment regimen. Always see your patients 3 to 4 weeks after a session. If you don't, you're going to miss an opportunity to evacuate intravenous thrombus, and you're going to wind up with more hyperpigmentation. And lastly, manage expectations of the patients early and often. So if we could run the video. Dr. Thorpe. Oh, so this goes real quick. So this is actually a patient right here. I'm going to show you. Can you pause for a second on that? So this is a patient who had had a vein stripping in the past, and she came in with this area of venous stasis, a lot of pain, a lot of induration. She had no saphenous vein. I couldn't even identify a perforator. All we saw in ultrasound was a whole plexus of varicose veins underneath her skin. And so we treated her with ultrasound-guided sclerotherapy, and that's the first thing I'm going to show you. So you can go ahead and let it roll. You can see she really almost had no visible varicosities here. But that's what her leg looks like. It's kind of indurated, it's red, it's inflamed. And this is just showing the ultrasound picture. The ultrasound's kind of hard to do in some of these because you can't get the entire probe flat on the skin, so you'll see it'll lift up a bunch. But I've identified 2 areas that I think if I inject, I'll be able to take care of most of the veins. The first injection is with foamed Sotodecol. And you'll see in a second, you'll see my needle, and I'm using a 25 gauge needle. You'll see it there at about 10 o'clock, penetrating the vein. I'm sure I'm in the vein, so I'm not aspirating. And I'm going to just inject. And with foam Sotodecol, you're going to see the starburst of pattern as it disseminates throughout the vein. And you're going to see it just sort of appear here, and then it starts to create acoustic shadowing throughout the vein. And I'll actually use the ultrasound probe to massage it up and down the leg to get as much of the vein covered with it as I can. I'm sure she had several microscopic perforators that were feeding these things. I just couldn't demonstrate them with ultrasound. You'll kind of slowly see the vein go into spasm over time. And so that's the first injection. I probably injected I injected 3 cc's of 1.5% Sotodecol there. And now I'm just literally massaging it up and down the leg with the ultrasound probe. If you were to lift the leg up, the foam would rise and you would get it to go down the foot. If you were to hang it down, the foam would rise up into the thigh, which we try to avoid doing. Now my next injection is going to be just with liquid or aqueous Sotodecol. But again, it makes it a lot easier if you have a few little bubbles in it. So what I do when I use aqueous and I use ultrasound is I actually shake the syringe a few times to create some air bubbles in it. And I think you're going to see here in just a second, you're going to see another needle come in the vein here. Well, maybe you are, or maybe you're... There we go. So again, these segments, particularly when you can see the needle, I'm trying to cannulate the vein right there. And you can see my needle's in. And even though this is actually aqueous, because I've shaken it, you'll see a fair amount of bubbles within the solution, which help you to maneuver it up and down. And again, I'm sorry that I'm losing contact here, but the skin was very dented and irregular. But that's basically how you do ultrasound-guided sclerotherapy. 25 gauge needle works great. It's very easy to see with ultrasound. Use the ultrasound probe. If you don't want the solution to go up above, you can press the vein up above so all the solution stays below. You can use your probe to move it wherever you want to move it. So that's ultrasound-guided sclerotherapy. It's useful for patients with neovascularized saphenofemoral junctions. You can actually cannulate each one of these branches in the thigh and inject sclerosant to seal it. Would you keep the video going? There's actually like a 30-second pause in between each segment. The next thing we're going to see is regular sclerotherapy. And this is, again, using a vein light. So you can see that we're surveying the skin with a vein light before we do anything. And you can see this patient, it's a medial thigh. We've wiped the skin down with alcohol. And you can see it's difficult to photograph this, but right there you can see, I think, a reticular vein. And in this case, you could kind of see it through the skin. But we're going to use a vein light to guide, and you can see the vein actually disappear. And again, with the vein light, you can hold pressure on it in one end or the other to get the sclerosing solution to go where you want it to go. You'll notice that we don't really aspirate. It's difficult to aspirate when you're doing sclerotherapy because by the time you reposition your hand to aspirate on the syringe, the needle has frequently come out. After you've done this enough, you actually get a feel for when the needle is in the vein. And when you're watching, in this case, you can just literally, once you inject, you can see the vein just disappear right before your eyes. And now we're doing dermal spider veins here. And again, just very low pressure. You'll notice that the needle is going almost parallel to the skin. If you have any degree of angulation on your needle at all, like I think she did here, you're going to go right through the back wall of the vein. And that's what happened there. So you have to be very parallel and with gentle pressure on the plunger. And as soon as you get in the vein, you see it blanch. If you wind up giving a little intradermal injection, then we're going to wind up just massaging the skin a little bit to disseminate the solution. And it really won't cause any problems at all. And we literally just march around the vein. Generally, the 30-gauge needle stays sharp for 5 or 6 injections, and then you need to replace them. That just shows the needle being bent at the hub a little bit. You don't want to bend it too much. And you can see, just again, if we were blasting with pressure, I could make that whole thing fill with sclerosant with one injection. But that's really not our goal. Our goal is to just cover a little 2 or 3 centimeter area around each vein and then move on. So we might, to treat what you see there, that might wind up being 6 or 7 injections. And it's kind of nice while you're doing this, you have the opportunity to talk to the patient. And, I think patients sort of enjoy the fact that they have a little bit of activity during this to distract them. We do not use lidocaine beforehand. We don't wrap the legs, and I'm curious to hear a little bit more about that. We do this all strictly without any anesthesia. And this part here, it's a 30-gauge needle. You can see on the left there, you expect to see a little bit of an urticarial reaction in the skin after the patients have had their sclerotherapy. Generally, if you don't see anything when you're using sotodecol or a sclera, your solution hasn't been strong enough. If you see a really intense reaction, you're probably using a solution that's stronger than you need to. And again, generally anywhere from 50 to 80% of what you inject each time actually is affected by it. We'll spend about 20 to 25 minutes injecting a patient on each session. We spend 5 minutes beforehand assessing the results of their last injection and evacuating any thrombus, and then another 5 minutes putting dressings on the patient's leg and reviewing their discharge instructions with them. And it just kind of goes on and on and on and on. So, are there questions? Romy. Well, my nurse does it. Generally, she spends about 20 to 25 minutes, as much as she can do. I think we're a pretty good value in sclerotherapy. We do a lot in one session. I know, for instance, that at some of the vein clinics, they do 8 sessions per leg, period, automatically every time, no matter how many veins you have in your leg. But we try to do as much as possible. We try to get the patients in and out. They have better things than doing. Oh, well, we do as much as they have. We'll do an entire leg at one time if the veins aren't. Generally, we'll use about 9 cc's or 3 syringes of sclerosant at a time. Well, at this time, she's using sotodecol at 0.15%. And so that's probably for veins. You know, the smaller the vein, the lesser the concentration. But generally for veins of this size, if you're going to use sotodecol, you're going to use anywhere from 0.1 to 0.15. And if you're going to use a sclera, you're going to probably use 0.25 to, 0.3% a sclera. And we actually prefer sotodecol, mainly just due to the price. You know, it's a lot cheaper than the Sclera. You have or you have not? No, and we have not either. Did you have something you wanted to add? Oh, I thought you were going to say.
No.
Okay.
Well, I was about to say that our session lasts for an hour in Brazil, and we do the most that we can, because when you use glucose, you don't have a certain volume that you have to stop, so just keep going. And I was doing the math here that one vial of glucose in Brazil costs about $2. So you can just use a lot of them, 2, 3, or 4 vials, and it will be okay. So we just keep doing an hour of sclerotherapy for those patients.
So you use 50% glucose.
Yes. We start with 50%. On the market, you have 25%, 50%, and 75%. So you can combine those vials, so you can have 62.5 or even higher concentration. So, but we usually start from 50% and go higher. And you said that you don't go too far with your injections. And what we are doing now in Brazil is that we go that far, because if they do mix with blood, but you don't know where this is going to happen, right? So we just do an injection, a full injection with no pressure, and this is the most important thing. So we do a full injection if you get a wider vein, and it goes all the way, so we just keep injecting. And the next time, and the good thing about in Brazil is that the patient wants to come back every 15 days. So we don't have that problem that they don't come back and you don't find, any complication that you had. But since we use glucose, and there are very few cases of true complications with those patients, so they keep coming. And when this happens, you just catch it up on the next session. Well, the feeding veins, we treat the feeding veins. You can choose between foam, sclerotherapy, or just using the glucose. It all depends on the diameter of that vein, the feeding vein. But we use the vein light to find that feeding vein, and we start from there. Yeah. Yeah. Yeah, we started with those. Well, you can only inject 1 milliliter of glucose, and then we moved to 2, to 3, to 4, to 5, and everyone was doing this, in São Paulo. So the next meeting, we found out that everyone was doing that, just because since we don't have that many complications, you can just go over, and the next visit, you will find where the glucose stopped and where you have to restart and go on.
Questions? I'm sorry?
Well, we mix with lidocaine. They just come with small amounts of, it's 0.1% of lidocaine. So they just have the lidocaine with the glucose. They come all together, ready to go. So, but it's not painful at all. I mean, patients usually complain when you're doing on their feet, on their foot, but otherwise they don't complain at all. No, this is very rare, very rare. And I saw when they pushed too much, and the vein just ruptured, and you had glucose all over the under the skin. So they had an ulceration. It's very rare.
Question?
When you're injecting a perforator, do you inject directly to the perforator, or how far away do you inject the perforator?
I try to get as close to the perforator as I can, but again, that's where I'll use a foam solution, but I truly might use a half a cc of foam. I mean, just enough, and put some pressure on it, and it just sits there, and that's all you need. You don't want to be injecting 2 or 3 or 4 cc's, because that's going to go in the deep venous system. The problem with foam when you do it for the great saphenous vein is really not getting it through the saphenofemoral junction. It goes through the perforators into the deep venous system and causes problems. So, I'll generally use 1.5% sotodecol foamed.
Yeah.
No, I actually was, no, I'll take, I usually dilute it, I usually foam 2 to 1. So I'll take 1 cc of 1.5% sotodecol and mix it with 2 cc's of air and foam back and forth. But, some people do it 1 part to 6 parts. It doesn't, when I've done it with any less than that, it just doesn't seem like you're injecting a whole lot of solution in patients. But again, I would tell you, if you're going to do foam, you start off with small concentrations, and we never use more than, as I say, 6 cc's at a time.
Yeah.
And as far as using glucose, stick, once, I might start trying glucose, but I've been doing this 25 or 28 years.
No, just
And so I would not recommend that you start off your sclerotherapy practice by injecting hypertonic glucose in patients. I may dabble with it because I'm very curious now, but start off with sotodecol or a sclero, the approved agents. Stick to the book, use one, learn it, then go on to your next agent. Dr. Thorpe, and then I'll get you.
Do you think everyone's abandoned the idea of having to use CO2 and just use room air for this?
Yeah, I don't know of anyone that's still using CO2. So one of the ways people were trying to avoid the neurologic complications of foam solution was using carbon dioxide. But to me, the whole purpose of foaming something is you want it to stay a foam for a long period of time. So if you're using carbon dioxide, it's going to rapidly get dissolved, and I don't think it's going to have the same effect. So I don't know of any product that's under development related to CO2. The foam product that's before the FDA now, well, I can't say what's in it, but it's not CO2. So, and then over there, you had a question? Okay. Right, and that's the issue with foamed sclerotherapy agents. Whenever you use anything foamed in the leg, if you want to start to sweat and get a chill down your spine, examine the common femoral vein when you're done, because you will see this starburst of foam that's sitting in the common femoral vein no matter where you injected it. So there was a report in the Journal of Vascular Surgery about 6 years ago of a patient who became hemiplegic and aphasic during a session of foam sclerotherapy. And the surgeon was bright enough to actually put a carotid ultrasound probe on the neck, and he could actually see the foam bubbles bouncing off the carotid bifurcation. It was in the publication. I'm not, speaking out of school here, but he'd actually used 25 cc's of foam during that session. So I think that if you use a small amount selectively, you're going to be okay. I'll either use a butterfly or I'll use just a standard 25 gauge needle. We use both. What do you use?
Ultrasound guided with a butterfly.
Butterfly. Great. Anything else? Dr. Thorpe is coming to the stage.
Thank you. Oh, I want to thank everyone for staying for the afternoon, and I think there's going to be an industry-sponsored reception here in the exhibit hall. So, and we thank all the vendors for supporting this meeting. And tomorrow we're going to embark on more DVT endovascular procedures in the deep system. So I hope to see you all back, plus more for the morning. So thank you very much.